Hello, everyone, and welcome to today's webinar, Advancing CPO Screening, Integrating Molecular Techniques for Better Lab Practices and Diagnostic Stewardship. I'm Cassie Siltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more, visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We do ask that when submitting questions that you make a note of which speaker your question is directed to so that we can ask them accordingly. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you're having trouble seeing or hearing the presentation. We will not have subtitles for the presentation during this live session. However, subtitles will be available in Spanish, French, and Portuguese for the on-demand period, and you can find links to access those below in our resources component. I'd like to now welcome our speakers joining us today. First is Professor Rodrigue Dessein. He is a professor of microbiology, head of the Microbiology Department at the Lille University School of Medicine and the Lille University Hospital Microbiology Laboratory, and is senior researcher in the OpInflELD team led by Professor Gosset at the Center of Immunity and Infection of Lille University. He has a strong background in experimental research on gut mucosal immunity and microbiome interactions. His past work includes a probiotic approach using genetically engineered food-grade Lactococcus lactis and on-gut microbiota-derived TLR2 agonists in germ-free mice that restored colonization resistance. He brought this expertise to the OpInflELD team, leading to work showing that antibiotic-induced gut dysbiosis modifies the lung immune response to P. aeruginosa lung infection and worsens outcomes through a depressed gut-lung immune axis. He has extensive experience in coordinating projects involving translational research consortia. He is implicated in hospital to stewardship in anti-microbials, especially in ICU and hematology, since 15 years. Dr. Ricardo Kosop is an esteemed infectious diseases physician and the medical coordinator of the antimicrobial stewardship program at Hospital Angelina Caron in Brazil, a philanthropic hospital with more than 400 beds and 1.5 million clinical and surgical procedures a year for patients from the Brazilian public health system. As the CEO and CMO of Lab Kosop Medicina Diagnostica, Dr. Kosop is deeply commissioned to promoting the rational use of antimicrobials and raising awareness about microbial resistance. With a strong interest in diagnostic stewardship, he advocates for the optimized and rational use of diagnostic tools as a key component in enhancing the quality and efficiency of healthcare delivery. His passion for these areas drives his dedication to improving patient outcomes and advancing the field of diagnostic medicine. Also joining us for the discussion during our Q&A session today is Ana Maria Cardenas, Senior Director, Global Medical Affairs with BD, and Becca Martin, Manager of Medical Affairs with BD EMEA. Ana Maria will relay questions to Dr. Kosop, and Becca will relay to Professor Dessein. With that, I'd like to invite Dr. Kosop to start with his presentation.
Okay, so hello everyone. I'm glad to be here today speaking about my experience as an antimicrobial stewardship coordinator and also the CMO and CEO of the Lab Kosop. It's a clinical laboratory that provides the hospital where I work with the laboratory tests and results. And well, to begin with, these are my disclosures as the Brazilian law recommends. And well, I'm speaking from the south of Brazil, from a city that's called Campina Grande do Sul, at the state of Paraná. It's a city that's at the metropolitan region of Curitiba. Curitiba is the capital city of Paraná. And at this hospital, we are one of the largest clinical centers for patients from our unique health system, from the public health system. So it's a philanthropic hospital that takes care of many patients from the Univ system, from our Brazilian healthcare system, and also from private healthcare plans. But major is the major healthcare center in SUS in Paraná, and the 6th in Brazil in volume of patients and procedures that are undergone in our hospital. We also have the biggest renal transplant services in the state of Paraná, and also fairly good surgical and clinical oncologist teams that work here. And we have 466 hospital beds with 7 ICUs, so with a very large range of spectrum of patients and complexities that we take care in our hospital. And I like to begin my presentations always with, what do I believe in? So I believe that patients always should come first, because when we think that, when we have this mindset, I think everybody wins with a good healthcare delivery. And I also believe, and firmly believe actually, after these years of clinical practice, that cutting-edge diagnosis is as important or even more important than cutting-edge treatments, because we see that how much we could provide better treatments and better healthcare delivery when we have better diagnosis. We can treat something that we don't have the diagnosis, or the diagnosis is wrong, or in part or in totally wrong. So, but also with great powers come great responsibility, I said by Uncle Ben to Spider-Man. So we have to use them ethically, rationally, and always evidence-based. And I also firmly believe that everybody has the right to given universal access to high-quality healthcare, from diagnosis to treatment and recovery. And it's very important for us to begin speaking about CROs and antimicrobial resistance with our global challenge on climate change. So we can see that climate change impacts many aspects of our lives, and is not different to antimicrobial resistance. And we see it very firmly in the recent papers, and I highly recommend this series of papers that New England has released in the past months about the impacts on health based on the climate changes, on the effects of climate changes on water, on soil, on our air, and also the mental health issues that comes from, and economic issues that comes from these problems related to climate changes. And also something that I always like as an infectious disease, we always like to work with maps, and we can see here that when we look upon just only one bug, E. coli, one of the most frequent gram-negative bacteria that we come across in our clinical practice, we can see that how much resistance is E. coli in our clinical practice, on our everyday clinical practice, ranging from 20 to 60 or even 80% resistance to cephalosporins, one of the most important drugs that we use to treat community-acquired infections and even hospital-acquired infections. And we can also see here the burden of antimicrobial resistance at a glance on low and middle income countries. And it's also known that overuse and the irrational, inadequate use of antimicrobials plays a huge role on antimicrobial resistance. So this is a CDC chart that shows that only in the US, for example, the majority of patients will receive an antibiotic for commonly acquired community infections like community-acquired pneumonia or urinary tract infections. We also have a high burden of disease that comes from these infections, but also from the prescription of antimicrobials for infections. Then, for example, for the respiratory tract infections, we know that they are mainly caused by viruses, but still these patients receive some kind of antimicrobial prescription, and also the prescription of some classes of antimicrobials that we know that are highly related to resistance induction, like fluoroquinolones. When we come and see how Brazil is the setting of Brazil about the antimicrobial resistance. So I bring this excellent Brazilian report that was released in July of this year, 2024, that comprises the data from a nationwide AMR vigilance network that comprises samples that are sent from healthcare facilities and clinical laboratories to the central laboratories, the state central laboratories, the central labs that proceeds with analysis of multi-drug resistant infections, contagious infections like tuberculosis, HIV, pertussis. And this report is very interesting because it brings us from 2015 to 2022 more than 85,000 bacterial samples with molecular testings for CROs. So we can see that the main genes that were tested at the license, and the Paraná, the LACEN from the state of Paraná was one of the cutting edge laboratories that worked upon this issue. And the data are very interesting because we saw at an alarming levels of resistance from Lactobacterialis coming from healthcare facility samples, and these samples were sent every time a sample would be, for example, Lactobacterialis resistant carbapenem in the phenotypical testing. They would be sent from the laboratory that did the first test to the LACENS, so we can see that for Enterobacterialis, especially Klebsiella pneumoniae and E. coli, we see that LAC-KPC is the most important resistant mechanism, but it's actually being decreasing, but not because he's fading away, but it's being the scenario is changing because NDM is taking place. When we see for known fermenters, we see that Pseudomonas aeruginosa, like for 10 years ago, we would say like Pseudomonas would be like if it's carbapenem resistance, so probably would be SPM, because actually it was the first time it was reported was in Brazil, SPM, São Paulo metallo-beta-lactamase, and it's actually decreasing rapidly from this in these past 7 years of the report. And Abelmani, interesting, is the most important, actually virtually the only mechanism for carbapenem resistance is OXA23. It's actually endemic for us, and we see in clinical practice how much this plays a big role when we conduct treatment on patients with Abelmani infections. We virtually have no antibiotics except for polymyxins, for example, and we know that also because OXA23 is our most prevalent resistant mechanism in Brazil, and it also plays a huge role inducing or these clones typically bring other resistant mechanisms, and Subactam, for example, has no part in our treatments, and we see on clinical samples that we don't have this option to treat our patients. When we see the bacteremias that we are reporting from our clinical laboratory here in Hospital Angelina Caron, it's very much similar for what we see from the other reports, and unfortunately we see that resistance is actually speeding up in a rate that brings a big alarm to our services. So we see that the majority of episodes from Enterobacterialis are resistant to third or fourth generation cephalosporins. But we still have, at least in the clinical samples from blood cultures, we still have carbapenems to rely on, but we see that especially from March to July of this year, we had an increase in infections. And these are not only hospital-acquired infections. We see infections coming from the community. We see it coming from patients from long-term facilities, from the primary healthcare facilities. So patients that we also see there, they are increasingly coming with multi-drug resistant infections. And we see, and when we look upon our staphylococci, we see that it's not so different for MRSA. So for a few years ago, we would not bother about treating MRSA from a community acquired perspective, but that's not the reality anymore. We have seen many skin and soft tissue infections with secondary bacteremia due to MRSA, CA-MRSA, and it plays a role here for at least 20 to 25% of our bacteremias, hospital-acquired or community-acquired, are due to, when it's due to Staph aureus, would be for MRSA. And we also would like to show you guys another report, national survey made for this national survey that was made was conducted by the Ministry of Health, and it evaluated how would Brazil be, the situation in Brazil regarding antimicrobial stewardship programs. So we see in this graph that for more than 1,200 hospitals that submitted to the national survey, the majority of them have an infection control program, actually because it's mandatory by law to a hospital to have a fully implemented infection control. But when we talk about the stewardship programs, antimicrobial stewardship programs, only less than half of them have any type of antimicrobial stewardship programs implemented in various complexity levels. And when we see why do these hospitals and healthcare facilities do not have an antimicrobial stewardship program implemented, we see that mostly because it lacks structure, lacks clinical laboratory, lacks microbiology, lacks support from higher management instances. So we see we are dealing with this major problem of antimicrobial resistance and overuse of antimicrobials, but less than half of our health facilities do have an antimicrobial stewardship program implemented. And just at a glance, an historical glance, it's also global problem. We are tackling antimicrobial resistance fairly recent in historical sense. So only in 1998 that state members of the Health Organization committed to tackle antimicrobial resistance, and only in 2015 we had a global plan that was published with clear objectives and how we should deal with these problems. And Brazil, we are not so much behind. Actually, in Brazil, we are fairly well understood the risks and the problems of antimicrobial resistance. And we should also point out the BRCAST publication that are TSA, antimicrobial susceptibility testing standardization that is fully adapted to the Brazilian reality. And in 2023, the antimicrobial stewardship program guidelines that was published from the Ministry of Health with clear objectives and clear purposes for implementing an antimicrobial stewardship program. And in the far axis, we see that promoting, in the fourth axis, to promote the stewardship programs in antimicrobial and in the health institutions. But also, when we talk about antimicrobial stewardship, we cannot dissociate it from good diagnostic stewardship program implementation, because improving diagnostic tests, we have better diagnosis, we have a better delivery of care, we have a better understanding of what infection is taking place, which bug is the bug that's bringing the illness to our patient. We know its susceptibility to antimicrobials. We can deal with better when we have a good diagnosis. And so antimicrobial stewardship and diagnostic stewardship, they are all balanced and work together to bring a better antimicrobial prescription and a better healthcare delivery for patients with infections. And it's also important to see that a good diagnostic stewardship program must rely on rapid diagnostic tests, because they bring rapid and quick answers for our clinical questions about our patient and the infection that's undergoing. But also, when we choose a good test, or any test you like, but especially specifically about the molecular diagnosis tests, we must know our tools. We must know what are we dealing with, which pathogens are we dealing with, and how can we use make the best use of them in our clinical practice. And I think the main message here is that every antimicrobial prescription is an opportunity for timely diagnostic stewardship interventions. So we can complement the antimicrobial intervention with a proper diagnostic tool to improve the diagnostic and the outcome of the patient. And here at a glance, we can see that it comprises from the pre-analytical phase to the analytical phase, the post-analytical, and of course, the antimicrobial stewardship and the evaluation of that antimicrobial that was prescribed. And we cannot talk about stewardship programs without talking about the economic impact that they bring to institutions. And it's important to rely on that, because many times the boards and directors of healthcare facilities, they must know their costs. And sometimes bringing ID physicians, ID pharmacists could initially present as a cost, but actually they are cost effective. Having good professionals that know what they're doing, know about antimicrobial resistance, antimicrobials, can bring also good results in the financial balance of the institution. And we can see here, I'm sorry, it's in Portuguese, but from the main 5 interventions that we undergo our patients, is because there's patients, they don't need antimicrobials, or the patient does have not an antimicrobial, so the patient does not have an infection, so it was an empirical use that is unnecessary by the time we the intervention was deemed. And also one of the major interventions that we do is to recommend, as antimicrobial stewardship professionals, to recommend or to deliver proper tests for these patients. And so we see that there is a huge cost avoidance that also brought the antimicrobial stewardship program in our institution as a strategic program that is being that's going on from these past 2 years to now. From now on, I would like to bring some clinical examples. So, and I like to use this figure, this person, Nelson Rodrigues, a Brazilian writer, and he wrote a series of short stories that are named A Vida Como Ela É, The Life as It Is. So, the life as it is sometimes is very different from the papers, from the articles, from the clinical trials. So I would like to bring you some examples from how we are using diagnostic tools to improve our stewardship interventions. So this case is a case of diarrhea in a child, a 3-year-old child that was admitted with sepsis and septic shock due to a community-acquired diarrhea. But this patient also had a previous hospital admission due to pneumonia, and of course, after using antimicrobials, he suffered with C. diff infection. So this patient was in a severe dehydration, and he was promptly managed with IV fluids, antimicrobials like a broad spectrum antimicrobials like ceftriaxone, metronidazole, and nitazoxanide for treating some parasites. But we also recommended as a stewardship program stool, blood cultures, and molecular panels for enteric bacteria. And for our surprise, and we ended with the diagnosis of Campylobacter, and you know that Campylobacter cannot be cultured in standard microbiology. For example, we need specific medium for that, and so we could promptly change the antimicrobial treatment of this child to PO, azithromycin, and not only recommending the right antimicrobial, but also helping the physician in the post-discharge follow-up, because we know what Campylobacter can represent to our patients. The other example is regarding our experience, our short course, but still very important experience for multi-drug resistance surveillance. So we know that it's important to manage. It's mandatory by law, but also we know the impact on bed rotations and how contact precautions can impact on patient safety. We know that patients that are under contact precautions, they have more patient safety events than those that are not under these contact precautions, and also impacting costs. We know that some hospitals that have made a few small trials showing that it's possible and cost effective, like this one in the state of Santa Catarina, and they had an important cost avoidance that was much higher than the microbiology, the molecular biology cost that was related to it. Not only and this cost was only when they analyzed the bed rotation. They did not comprise, for example, another costs that are also include, like PPEs and other precaution supplies. So here in our hospital, we did a project at an emergency department, because that's the main entrance for patients in our service. And we conducted simultaneously the rectal and nasal swabs. They were analyzed with standard microbiology cultures, and also the same samples were tested with molecular testing. And for our surprise, we saw that of course, we know that our antimicrobial resistant organisms, they are spread all over around, and we know the impact they come from different healthcare facilities. And we saw that more than 85% of patients did not need any contact precautions. But not only that, we saw that the molecular biology reduced significantly the time that patients needed empiric contact precautions. So in less than 8 hours, we had the results and could lower the contact precautions from the majority of patients. So we see that a good clinical lab and the stewardship programs, they come together. They are partners in delivering a better healthcare. So, but for that, we must rely on high-quality microbiology lab. We can and must integrate molecular testing with standard microbiology to other molecular and immunologic tests, for example. We should also rely on biomarkers to properly use our antimicrobials. And for that, my take-home message here are that the drug-resistant organisms, they have a global impact, but also we have global responsibility to tackle it. It's not only an issue to be tackled only by infectious disease physicians or microbiologists or pharmacists related to infectious disease. Also, we see that in our clinical practice, better and faster diagnosis brings better healthcare. So the stewardship, diagnostic stewardship and antimicrobial stewardship are tools for that, for us to bring these patients to a better outcome, especially regarding multi-drug resistance infections. They are cost effective even in low and middle income countries. We know that's the big challenge to tackle costs and to bring healthcare to these populations. But we also need more studies. We need to understand better our realities. Brazil also is a vast country, has more than 220 million inhabitants, and the different places in our country shows that we have a huge discrepancy between the regions about when it come across healthcare delivery. And I think the most important message is that a good stewardship program brings benefits to all, to the laboratory, to the hospital, to the patients, to the healthcare team, and to the society as a whole. Thank you very much for your attention, and I will be here to answer your questions as well.
Thank you, Dr. Kosop, for your presentation. We are now going to transition over to Professor Dessein's presentation, where he discusses BD-MAX system for CPO screening. Professor Dessein, you may now take it away.
Good morning, everyone. I'm Professor Rodrigue Dessein. I'm the head of the Bacteriology Unit at Lille University Hospital. Today, I will be sharing our experience with the BD-MAX system, focusing on its role in CPO screening at our hospital. Here is listed my disclosures. The Lille University Hospital is a medical center consisting of several buildings, each dedicated to specific medical or surgical specialties. Care, research, teaching, and patient transfer intake are the main activities promoted by our center. The microbiology lab is in a building that houses all the biological labs. You can see our central position that allows us to collaborate efficiently with all clinical departments. We manage samples from a wide range of specialties, covering diagnosis of both primary and secondary infections. The public hospital regional network serves a population of around 4 million people, and the Lille University Hospital serves as a referral hospital with a significant number of patient transfer intake. This situation impacts the epidemiology of our center, especially for carbapenemas. Antimicrobial resistance is not only a national issue, but a European one. According to the 2021 data from the European Centre for Disease Prevention and Control, we are observing rising resistance with the example of Klebsiella pneumoniae, resistant to third-generation cephalosporins. Carbapenem resistance in Klebsiella pneumoniae remains limited in France, under 1%, based on the available 2021 data. Another key pathogen of concern is Pseudomonas aeruginosa, with resistance to carbapenems in 10% to 25% of invasive isolates. But since 2022, we observe an increase of invasive CPO infections in isolated patients from multiple departments, including abdominal surgery, nephrology, urology, or oncology, and Enterobacterales in general have been implicated. Additionally, we've dealt with an outbreak of Serratia expressing the carbapenemas NDM1 in neutropenic patients in 2024, and another outbreak of Acinetobacter baumannii expressing the carbapenemase OXA23 in ICU at the end of 2023. This situation makes CPO a growing concern at a local level. In this context, we follow national recommendations to prevent CPO dissemination. Schematically, these recommendations range from strict contact precautions for patients positive for CPO to temporary bed closures during epidemic CPO outbreaks. CPO prevention and control measures increase significantly the hospital staff workload. Applying these recommendations relies heavily on active screening and surveillance of CPO. This active screening and surveillance of CPO also impact the lab workload too. We systematically screen high-risk patients for CPO colonization on rectal swab. Of note, patients coming from other hospitals are considered at high risk and systematically screened once admitted. We also implemented the BDMAX system in the lab 5 years ago. The BDMAX system is a fully integrated automated molecular diagnostic platform designed for clinical laboratories. Today, we use various kits on it, including the BDMAX CPO assay, the extended enteric bacterial panel, and the Biogix Mycoplasma Uraplasma panel. These have helped us streamline our diagnostics. Given the rising CPO cases and the hospital referral statute in the region, we implemented the BDMAX CPO assay with the goal of providing rapid results to help medical staff in implementing CPO transmission prevention measures and in preventing, in fine, CPO epidemic outbreaks. We use the BDMAX CPO assay for CPO screening only on rectal swab. Here come personal data. Between January and June 2024, we conducted nearly 10,000 CPO screening tests on rectal swabs. Of these, nearly 19% were negative, 7% were positive, and 0.5% were uninterpretable by the BDMAX system, requiring further culture analysis. If we take only the positive results, the data show nearly 400 CPO carriers after removing the duplicates. This high proportion reflects the complexity of patient cases taken in charge, the fact that many patients are transferred from other hospitals and have already received antibiotics, which is known to be a risk factor for carbapenemase acquisition, explain in part these results. Most of the cases involve the carbapenemase OXA48, which aligns with national epidemiology. As you can see, NDM1 was the second most common found carbapenemase in the rectal swab, correlating with the outbreak we observed in 2024 in neutropenic patients. Nearly 5,000 patients were tested negative, the majority after removing duplicates. The results were completed within 4 to 6 hours and transmitted electronically to the medical staff. This speed provided a significant advantage over traditional culture methods. We observed that the BDMAX system's rapid negative results has allowed us to de-escalate preventive measures more quickly, reducing the workload for the medical staff. Additionally, rapid negative results help us to de-escalate or limit the first-line antibiotic treatment. Also, negative results allow rapid reduction in infection control measures and more fitted antibiotic prescription, and positive results aid for implementing appropriate preventive action. Finally, implementing this system was a provider education for physicians on the use of molecular diagnosis for CPO screening. Concerning the lab, we've seen a 13% increase in CPO test volume over the past 2 years, and this automated system allows us to manage this increase without expanding our staff. However, proper technician training is crucial to avoid contamination, as the system is primarily operated by microbiology rather than molecular technicians. We've addressed these issues by implementing specific procedures in our quality management system. To conclude, the BDMAX system has proven invaluable in delivering rapid, reliable results. While most tests are negative, the waiting period before having the results can be associated with an increase of workload for the clinical world to implement CPO transmission and prevention measures. This waiting period could moreover represent a factor that encourages the physician to choose a larger spectrum anti-antibiotics first line. Therefore, providing rapid results, negative results, has been experienced as a valuable help for both CPO prevention and control and antibiotic stewardship. Thank you for your listening.
Thank you, Drs. Dessein and Kosop, for your informative presentations. We will now start the live Q&A portion of the webinar. I'd like to welcome Anna Maria and Becca to join us now. And to our audience, if you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for.
Great, thank you very much. Thank you very much to our speakers today as well. Very interesting presentations. So really appreciate the presentations that you both provided. So I'm going to start with a question for Dr. Kosop. Can you give any tips on how to address challenges you faced when trying to improve diagnostic stewardship?
Yeah, that's a great question, actually. Can you hear me? I think, okay.
Yes, we can hear you now.
Great. So I think that the first and foremost, you must understand your reality to know what are you dealing with, what is the reality of your services, of your healthcare institution, and map what are the main challenges you face in diagnosis and also in antimicrobial prescription, especially speaking about antimicrobial resistance. And what I faced, specific phase, was problems regarding how physicians perceive the interventions, but was rapidly tackled with speaking with the physicians and the medical residency coordinators and the teams as well. Also, we must overcome some problems regarding how these tests are prescribed. So we must teach specifically how to deal with these tests, how to order these tests, and also to interpret the results. So we must not only indicate the tests, but also be there and help explaining and helping the physicians to implement the diagnostic or therapeutic interventions as well. So I think the main tip is understand your reality and begin with the basics. Always start with a few tests, or only one test that you understand that it's most important for your reality. For example, we started when we implemented the procalcitonin. So it's a biomarker. It's very useful, but it also has many problems regarding interpretation. So we started like in small portions, and then you brought it to other tests and other realities.
Great, thank you. I believe you may have some questions.
Yeah, so this will be a question for Professor Dessein. And both of you can, of course, answer as well. But what are the advantages of the BD CPO system over other systems on the market?
That's a key question here. To generate rapid results, there is two times in the response. There is times on molecular methods. So molecular methods are very easy in my presentation for the negative results. I think that it's a key element. We focus a lot of positive results, but negative results could help the physicians a lot. So it's the clearly advantage of biological method. And today on the market, BDMax has a fully automated system that allows us to upscale the number of tests with non-specialist technician, because in our lab we have a molecular part of our lab, but for next sequencing, genomic sequencing, or for homemade PCR, and we place the BDMax with the routine, with the culture in the side of the culture. And BDMax is very interesting for that, because we can make a lot of range of tests.
I totally agree with Professor Dessein, and I'd like to point out that the fact that you can also prepare in-house tests, as you say, using this platform is partially open platform. So, for example, we are developing a specific test for OXA23. For us is a major importance, as you can see there, or even other tests necessities that you must have, but Dr. Dessein has explained the exact main issues that we undergone when we elected BDMax for us.
Great. As a follow-up question to that, is this test performed by special request, or is it an automatic laboratory reflex test after the AST?
So for us, as I said in the slides, it's not only automatic. It's to comply to recommendation. Recommendation says that patient at risk has to be screened. As you see, my hospital is central in the region with high level of resistance. So a lot of people have to be screened, have the criteria to be screened. So the physician prescribe a screening, and that's us, we choose the method. We explain the method that we are using molecular methods. We explain our colleagues how it works, but they do not prescribe PCR or culture. It's our strategy in the lab, and there is a confidence between the lab and the colleagues, and infectious colleagues, and ICU, and gastroenterologists, are all the colleagues. We explain before implementation of the tests, and we add comments in the report to explain the results. What is the signification of the results?
Yeah. Currently, we use as a reflex test, mainly in our ICUs and on the emergency department, depending on the history of the patient. But we plan to do as Professor Dessein said. So the physician prescribed the test, the swab test, for example, the rectal swabs, and then we would perform the molecular tests as well.
Great, that's very clear. Thank you. So the next question, I'll start with Dr. Kosop. Does your antibiotic stewardship program include automatic antibiotic therapy, stops or reviews of that? And if so, how many days post initiation of therapy would that stop or that review occur?
Great. For now, it's not automatic. So we have a team of ID pharmacists that review the antimicrobial prescriptions in the hospital daily basis, and elect the patients that should undergo specific tests, or mainly when we have this strongly implemented in our hospital, patients with any suspected infections, they are drawn blood cultures and urine culture samples whatsoever, but they have specific timeouts that the pharmacists they follow up the patients in antimicrobial therapy in these timeouts. For example, in the first day when the antimicrobial is prescribed, to see if it complies with the clinical spectrum that is needed. And pending cultures, we see this patient after 24 or 48 hours. So at least we would review this patient in the third day of antimicrobial therapy, and then with results in our hands, we perform the intervention in antimicrobial stewardship. But specifically for broad spectrum antimicrobials, patients do not keep this prescription without a review for more than 3 to 5 days. But it's not automated. We do it manually with this team, with our team of ID pharmacists, and also infectious disease antimicrobial stewardship team.
Great, thank you. This is a question for Professor Dessein. What feedback have you received from your team regarding the implementation of molecular, specifically BD-MAX, for carbapenemase screening?
Also, initially, the colleagues and me were not convinced at 100% because it was my former head of the unit that implemented this system. It's not me. So today I present I changed my mind during the course because we can't work without it today. Because as you see in the recruitment, we have a lot of increase. We see really the interest of the negative results with a high negative preventive, high sensibility of the negativity, high precision. And so it helps us. It decreased the lab work. And today we are very dependent on it because we are organized our lab differently. And you see the number of the tests, and there is also increasing. There are also increasing today. So the presentation is my point of view after 2 or 3 years of using this system.
The next question is for Dr. Kosop. So can you explain a bit more about the cost savings that you saw when implementing the molecular testing for hospital-acquired infections?
Great. So the cost avoidance we had implementing these tests, as we see that the majority of patients are not colonized by resistant organisms. So we reduced for that group of patients that I've shown in my presentations about 1/3 of the cost that we would have with contact precautions and a specific hospital bed for these patients, and to culture spending, result spending. We see that in less than 1 day we could just reduce the contact precautions and also the costs related to it, because many of our patients are from the public health system, and these payments they are really it's the value that these patients bring to the hospital. It's very preconditioned. So any cost that comes over it is for the institution to pay for it. So reducing the costs related to contact precautions, we reduce about 1/3 for these patients as well.
Great, thank you. So it's my understanding that Dr. Kosop, you not only looked at the cost savings from like the laboratory standpoint, but it was really a more patient holistic approach to the impact. Is that correct?
Precisely that, because for many hospital managers, they see the costs of the diagnostic tests only by the cost of the test itself. But when we see it as a whole, it brings a new and more holistic perception of the cost. So it's easier for us to implement these new technologies for new testings, for new protocols of testings, or not doing tests. So reflex tests, I think they also are easily implemented when we show these gains in a holistic way of analyzing this issue. So it's perfectly that way we see it, and how I try to implement these tests.
Thank you. So this is another question for Professor Dessein. What advice would you give to other hospital laboratories considering the implementation of molecular techniques for carbapenemase screening?
Yes, it's a very, I will respond simply to the question, but it's a very tough question because the holistic approach is very complicated in practice. So we have a great issue on money. And so it's difficult to have the money, even if we decrease the hospitalization and so on. So in practice, what is the medical goal for implementing this technology? Clearly assume the medical goal. 2, what the context and national recommendation, or how you have to comply with this recommendation. And 3, how you build the business model. Is that to decrease limit clinical charge, decrease limit lab charge, versus the price is cost and the money you are paid for the analysis. And it's an equilibrium between different essay and us in Lille. We choose that I have lesser money for other things, but that was a great issue for the lab, and we invest in it. So each lab has its organization, and that's the difficulty today, because we all want all the techniques.
Thank you. Very true. So you both, I think, touched upon a little bit about this next question, but it would be good to kind of understand a bit more how you do it in your institution. And I'll start with Dr. Kosop, but Professor Dessein, if you would like to add something, please go ahead. So a correct diagnosis leads to correct treatment, but often referring physicians are not familiar with necessarily the laboratory methods, right, and their advantages. And you both mentioned kind of having trust, right, between the lab and the physicians. So how can the laboratory improve that knowledge of those clinicians who request the tests? What do you guys do at your institution to be able to improve the knowledge of the clinicians on the other side?
Great. This is a very important aspect of implementation of newer and better diagnosis. Today, we have many clinical activities. The physicians are overwhelmed by the activities. So the best way to assess this is showing them at the bedside. And at the bedside, we will discuss the clinical case. You show the benefits and also the limitations of each test for each patient, and try to invest in micro learning. So sometimes I bring the medical residents together in a clinical round and discuss 2 to 3 cases in a very quick but direct way to show them how to interpret, how to order, how to analyze the limitations and the opportunities of each test. And I also give a tip to every lab professional is to get out of the lab, get out from the bench and go to bedside. So try to explain to patients and to physicians the tools that you have. Even the classical ones, the basic ones, they are still underused or misused. So it's a great opportunity to work and to implement and use it better in better ways for our patients and for healthcare.
Yeah, it's a complicated question. I'm teaching microbiology in the and antibiotics. If I make an image when a hematological lab discuss with the physician, he's hematology too, with translocation, with high techniques. For antibiotics and for infectious disease, we did not discuss all the time with infectious disease physician. It's a great difficulty. So to my part, I use BDMAX for screening and more for prevention transmission, less than taken in charge in antibiotics. It's a second astonishing results that we see that the first line antibiotics was was less large in the spectrum with the screening, because it's related to the stress of the physician. That is not infectious physician. That is not a physician specialized in infectious disease. So the difficulty for me is to explain the test to non-specialist colleagues. And we see it during COVID-19, between the serology, the PCR, it's very, very difficult to explain simply. So the trend today is to simplify and to say to our colleagues that they want screening or diagnosis. If they want screening, it's the part of the lab to assume to communicate the strategy in front of a screening. If it's diagnosis, it's simple to say, but it's difficult. It's an everyday challenge for us.
Great, thank you. And then another question for Professor Dessein, but I think both of you could probably respond to it. How do you perceive the evolution of carbapenemase-producing organisms, and what level of concern does this raise for your laboratory and broader healthcare settings?
It's ambivalent because it's a great concern. For specialists, it's a nightmare. The increase is a nightmare. However, when you see my data, a lot of samples are negative. The majority. The increase is real. The increase of carbapenemase is real. The outbreaks are real. But in practice, my colleagues do not have the mining that is yes, it's a problem. It's a problem for infectious disease and microbiologists, but not for me. So it's ambivalent. It's a real problem, but in practice, it's difficult to motivate our colleagues in this question. Locally in Lille, I am not speaking for all the world. But it's striking. But when they have one infection to CPO, they change all their mind. They increase antibiotics. So there is a lot of need of a lot of education to our colleagues. And for me, it's challenging all the system of care. The transmission, the colonization, the difference between colonization, infection, it challenges all the system because it's touched all the patients potentially, and we have a lot of work of it on this issue.
Yeah, here we see these alarming rates of antimicrobial resistance that for now, at least, we see that for many years, actually, like Professor Dessein said, the physician, the other specialties, the other physicians, it's a problem for other patients. Or eventually, I see a patient with a multi-drug resistant bug. But in our reality in Brazil here, when our hospital receive many patients from other healthcare facilities, emergency departments, and we see that this places a big challenge in treatment as well. So we see that this impacts in costs, in patient outcome as well. So we see that patients with Acinetobacter baumannii, they die earlier, they spend more time in hospital beds, they have a great amount of costs related to it. So it impacts in the whole system as well. And now this real challenge is being perceived by many other specialties and also the hospital management teams and also the public health system as well. So it's a clinical challenge, it's a money-related challenge, and for the lab, actually, it's not a big challenge because we have the tools. The main problem would be the cost of implementing these new tools or molecular-based tools, for example, but as shown, the majority of patients still are negative. So for screening perspective, it's easier in a way. It's easier for us to to tackle it. But many of these patients, especially if they are critically ill, the colonization turns to be afterwards some kind of hospital-acquired infection. So yes, it's a great deal of concern that we are facing today.
Well, thank you both for sharing with us your experiences today and your thoughtful response to the questions we received. I will pass it back over to Cassie to close us out. Thank you so much.
Thank you, Anna Maria and Becca, and thank you again, Dr. Dessein and Kosop, for your time today and your important research. We would also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand and will be available with the 3 subtitles in Spanish, French, and Portuguese. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Bye.